But first, I'd like to talk a little bit about our organization, Healthcare for All Ohioans. Um, I would start by thanking the state director, Kendall Mays, who has allowed us to do this, and all of our coordinators. I see Jennifer Lopez and Kathy Caraway. Of course, Bob's a coordinator. There's Nancy. Yeah, everybody's here. So all of our coordinators from around the state, and all of our members of the council. So I'd like to start first by talking a little bit about the history of Healthcare for All Ohioans. Healthcare for All Ohioans actually started as an organization called SPAN Ohio. It began in the early 2000s as a central organizing force for a single-payer healthcare movement in Ohio. Formed after the 1990s failure and frustration of the Clinton efforts. Recognizing the need for a broader coalition, SPAN activists organized a statewide conference in early 2003, and major labor organizations joined as well. Ohio AFL-CIO, the UAW endorsed the campaign. And the momentum was growing and led to a Single Payer Action Network Ohio, SPAN, SPAN Ohio. As support grew, SPAN considered launching an initiative petition campaign to put single-payer healthcare on the ballot. Now that campaign did quite well early on, but ran out of steam and eventually did not make it into an initiative ballot issue. What we did do, though, is introduced the legislation that was on our petition, basically mirrored our petition, in as early as 2003. Actually, it was September. Yeah, it was introduced in September of 2004. I'm sorry. Kudos to Mike Skindle if he's out there. Thank you, Mike, for carrying that bill for so long. His steadfast advocacy for this concept put us on the map. Our current legislation in the General Assembly, the 136th Ohio General Assembly, is Ohio House Bill 289 and Senate Bill 78. If you can become a member of the Healthcare for All Ohioans group tonight or in the future, you can attend the next sponsor testimony of Senate Bill 78. In this particular General Assembly, you've already missed the sponsor testimony for House Bill 289. That has already taken place. After the initiative petition campaign was abandoned, I should say, I suppose, effective in June 1st, 2016, another organization called Healthcare for All Ohioans was formed. We formed this organization to be more of a education organization. It is a 501c3, and charitable contributions can be given to that organization for the purpose of educating the public on the issue. At Healthcare for All Ohioans, we believe that everybody should have access to healthcare without fear of cost. Universal healthcare coverage that should make everybody included and nobody left out. We envision every resident with guaranteed full and comprehensive coverage, including hospitalization, prescriptions, vision, dental, mental health, home care, long-term care, and coverage for injuries and illnesses of all types without financial barriers. Membership is open to individuals and organizations who pay dues on a yearly basis and can vote in and hold office in our state councils. We advocate for a public fund. This is what is contained in our legislation. A public fund that will pay all healthcare bills without copayments or deductibles. Funding would come from current statewide health expenditures, savings made by eliminating administrative waste, and from the multitude of private insurance companies that are currently operating in the system. And of course, those pesky HMOs that have so bothered the practice of medicine. The savings from, and finally, the savings from greater utilization of preventive medicine so that everyone gets to see a primary care physician when needed without that financial barrier. The plan we call for is known as a single-payer healthcare system. So I'd like to take a couple of minutes here just to talk a little bit about what's coming up in the near future. April the 25th of this year will be our biennial state conference where we all get together in Columbus. You can go to our website, healthcareforallohioans.org, or if it's simpler, spanohio.org, and see all of the particulars on when and where we'll be having the conference and the particulars on the costs, so forth. It'll be a full day of presentations by people like Alex Lawson from the Social Security Works, Rose Roach, who's from the Labor Campaign for Single Payer Healthcare, and a former politician who's now the CEO, Planned Parenthood of Southwestern Ohio, Nan Whaley. In the afternoon, we'll have more local presentations by folks out of the Cleveland area. The concept is everybody's in and nobody's out. All right. So moving forward, I'd like to take a moment to introduce our first speaker, Dr. Valerie Fouts-Fowler. She is a respected pediatrician who served thousands of children during her tenure at university hospitals in Cleveland. Recognized for her dedication, she was named to the Cleveland Magazine Best Doctors list. Dr. Fouts-Fowler is known for her commitment to patient care and advocacy. In 2024, she courageously raised concerns about systemic issues affecting patient safety, including understaffing in the emergency room and delays in processing critical blood tests for young patients. Her unwavering dedication to her patients and advocacy for safer, more effective healthcare practices have made her a trusted and valued member of the medical community. In June of 2025, Dr. Fouts-Fowler and her colleague, Dr. Lauren Bean, were fired from university hospitals in Cleveland for allegedly organizing a union for doctors at the hospital and for fighting for rights of patients. Dr. Fowler, please unmute your microphone and help explain to our call participants your perspective on moral injury, where doctors are being blocked from delivering the best possible care their patients need. The floor is yours.
Thank you. Good evening, everyone. I just want to share a little bit more of my story and the reason that I'm standing here and why these conversations are so important. Thank you, Kurt, for the introduction. I trained in Cleveland at Rainbow Babies and Children's Hospital and then went to work for a West Side practice that was owned by university hospitals. And I worked there for 12 years and had about a panel of about 3,000 patients. So I love being a pediatrician. It's an amazing job. You know, the relationships I built with my patients and their families are incredibly special. I cared for children through, all the usual sorts of things, asthma attacks, broken bones, anxiety, and so many other struggles. But my special interest is in pediatric mental health. So I took care of a lot of patients with depression, anxiety, ADHD, things of that nature, autism spectrum disorder patients, some are my favorite. I watch toddlers, become teenagers, and teenagers become parents, some of them. I've been in it long enough for that. And for many families, I feel like I wasn't just their doctor, but kind of an extended family member. And I think it makes a difference when your doctor knows you. When you can walk into a room and look at your patient and say, something's not right, just because you know them. And I think everybody deserves that. I mean, I remember one patient, I went in and he wasn't there for his appointment. It was for his sister. But something was off. His demeanor was off. He's normally a very jovial, energetic, bouncing around child. And he wasn't. He was grumpy and just different. And it turned out that he had new onset type 1 diabetes. And I think that being able to, not that it wouldn't have been found out eventually, but being able to know your patients and be able to just know when something's not right is incredibly important. And I don't think there's a price that you can put on that relationship, really. But something was beginning to shift in medicine. Like so many other physicians across the country, I started to feel, the tension between what my patients needed and what the system demanded. Productivity metrics became even more prevalent, even if they did not improve outcomes. And the administrative layers grew thicker. Decisions that were affecting my patients and their continuity of care were being made not by me, but by people no longer in the front lines, by the administration. And I was watching all of my peers, suffer the same problem. Many left seeking a better environment elsewhere. Some left medicine altogether. I watched over and over the physicians feeling silenced, and that moral distress, that kind of guilt in your soul, for lack of a better description, of wanting to do the right thing for your patients, but being constrained by the corporate structure that was prioritizing revenue over relationships, really. So when my patients weren't able to get their care, when they weren't able to be seen, I often would diagnose children with, developmental delays and refer them to a specialist. And it was at the point that you could get a visit in 12 to 13 months, which was completely unacceptable. And so I did speak up. And the more I spoke up, the more I heard from other providers, and much more egregious complaints were coming through. So several of us decided that we needed to make a change. We weren't hearing any change being made, more just, there isn't money for that sort of answer. And so we decided we were going to organize a union at university hospitals for the physicians, not for higher salaries. I think that's important to point out, but for patient safety, for our voices to be heard, for us to be able to practice medicine ethically. And I believe that it's a way for physicians to reclaim our role in shaping the system. Otherwise, if doctors are silenced, it's the patients who suffer. And for that effort, I was fired. And that is an ongoing battle that's in the National Labor Relations caseload, as well as a civil suit. But what I gained was more clarity that this is not an isolated story. I wish it was. It is not just about one hospital in one city. It's a national story. It's about doctors who entered medicine to heal and now are dealing with billing codes, prior authorizations, and various financial barriers that are standing between their patients and care. It's about families who leave the hospital not only with new diagnoses, but with a tremendous amount of debt. It's about families that won't even go in for the healthcare to begin with because of the risk of becoming in debt. This is a healthcare system that is technically advanced, but increasingly unaffordable and not personal. And it's, in my mind, an urgent need to reimagine what medicine should be. That's why I'm especially honored to introduce our speaker tonight, Dr. Anand Habib, who's a physician at University of California, San Francisco, where he practices adult hospital medicine, which I give huge kudos because I like the kids. He received his Bachelor's of Science with honors in biology and international security studies from Stanford University. He then studied medical anthropology at Oxford as a Rhodes Scholar, earned his MD at Harvard Medical School, and completed a Master of Health Sciences at Yale School of Medicine. Well, what truly distinguishes Dr. Habib is not simply the prestige of his training, which is impressive, but it is the focus of his work. Currently, his research and advocacy examine the toll that health-related financial hardship has on patients and their families, and how clinicians can better engage in cost-conscious, patient-centered medicine. For the past 18 months, he's worked alongside organizers and leaders of physicians for a national health program to illuminate the magnitude of moral injury among physicians in an increasingly corporatized healthcare system. He brings intellectual rigor, he brings lived experience from the bedside, and he brings a moral clarity that many of us have felt but have struggled to name. Please join me in welcoming Dr. Anand Habib.
Thank you, Dr. Fouts-Fowler. Thank you for your testimony, and thank you also for everything you're doing for your patients and for your community. So I'm going to share my screen and let me know if you can see it. Okay. Can you all see that? Fantastic. All right. So I'm going to jump in, and I could not have asked you to set the stage more perfectly for what I'm about to talk about. Okay. So the title of my presentation today is Sounding the Alarm, Physician Moral Injury. So I want to start with a rhetorical question, coming back to what Valerie was talking about. So what is society, what is American society hiring healthcare to do? This has been the subject of a lot of debate, but Don Berwick, who I hope he would consider himself a single payer advocate, but he started the Institute for Healthcare Improvement in around 2008. He and his colleagues said, initially, healthcare has a triple aim, which eventually became the quintuple aim. So reducing per capita healthcare costs, better patient population health outcomes, and improving individuals' experience of care. That is individual satisfaction, individual patient safety and quality. In 2014, there was increasing recognition that many communities, especially rural communities, were facing a clinical shortage. And so this sort of idea of promoting healthcare workforce well-being was added. And then in the midst of COVID-19, advancing health equity. So I'm going to talk particularly about promoting healthcare workforce well-being, but I think it's important to sort of maintain this context. So when I went to medical school, when Dr. Fouts-Fowler and many of you went to medical school, nursing school, a lot of us thought that sorry, that healthcare was about the clinician and the patient. But increasingly, there's a whole host of actors who are in the hospital, in the clinic with us, the provider organizations that are increasingly buying up clinician practices, but also this whole host of other individuals, government actors like the Centers for Medicare and Medicaid Services, insurers, pharmacy benefit managers, politicians, pharmacies, pharmaceutical firms, and medical suppliers. And all of these individuals are seeking to maximize revenue and minimize costs, and ultimately affect the quality of care and the accessibility of affordable care for patients, such that if you get your health insurance through your employer or otherwise, you're having to go through a book of benefits and try to make heads or tails of, okay, I'm on these medications. What is the formulary through my insurer? How much is it going to cost me out of pocket? You're receiving unsolicited queries from insurance brokers asking you, oh, open enrollment has started. Do you want information? And unbeknownst to you, there's a financial incentive for them to steer you into particular plans. So when healthcare is not a right, when we don't have a single payer system, when we don't have Medicare for all, markets respond to incentives. They seek to control the supply of healthcare and labor. So as Valerie was mentioning, healthcare institutions, nonprofit or for-profit, seek to vertically integrate, buy up community hospitals, primary care practices. Entities like United Healthcare now control 10% of the physician workforce, in addition to controlling their own pharmacy benefit managers like Optum Rx. They emphasize documentation for charge capture. In my own contract through UCSF, there's a line that says that I promise to do everything within my power to ensure adequate revenue capture for the institution. They fetishize efficiency and productivity. They seek to understand, okay, we give you 20 minutes for a clinical visit. Can we go to 19 minutes, 18 minutes, 15 minutes in order to, again, maximize revenue? And then they manipulate demand. They tie insurance to employment. And increasingly, whether you get your insurance through the marketplace or through your employer, we're being subjected to high deductible health plans and increasing out-of-pocket costs, such that some 40% of US adults, or 100 million individuals, have medical debt today. And financialization, in some ways, is this peak form of capitalism. So what is financialization? The shift from the primary objective of healthcare being patient care and community health towards extractive production of wealth for equity owners and management. So a lot of the discussion around clinician and physician well-being has centered on burnout. And indeed, the National Academy of Medicine in 2024 put out a report, and in its introduction, they acknowledge this. They say, for decades, healthcare workers have been recording a loss of meaning in work due to overwhelming job demands and limited supportive resources in the environments in which they operate. In the US, up to 54% of nurses and physicians, 60% of medical students and residents, and 61 to 75% of pharmacists have symptoms of burnout, high emotional exhaustion, depersonalization, a low sense of personal accomplishment. And burnout is a longstanding issue. I think implicit in this is this idea of operational demands, long work hours, and staffing. And I think what has arisen as a result of that is this focus on an individual failure of resourcefulness and resilience. And that ultimately leads health systems to have chief wellness officers or physician experience leadership. I don't know if any of you have seen The Pit on HBO Max, but there was a clinical social worker who, after watching The Pit, said, "The Pit frames exhaustion as burnout, a depletion of the worker's internal battery that just needs recharging. And this implies that the problem is a lack of resilience. If you were just stronger, you could handle this." I think as I was talking with Dr. John Ross just prior to this, around 2019, 2020, there's a psychiatrist, Wendy Dean, who, in her assessment of the literature, particularly among the veterans with whom she was working, who said, gosh, well, this definition, this diagnosis of burnout is incomplete and insufficient. So what is moral distress? Moral distress, as first formulated in 1984, said it's when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. It has a couple of different elements. So Beth Epstein, whose work I'll come back to later, said it's this feeling of complicity and wrongdoing associated with transgressions of professional values. This feeling of a lack of voice or agency, particularly as health systems grow larger and larger and more divorced from the bedside. And it's repeated experiences with morally stressful situations. Moral injury takes it a step further. There's this crescendo effect. When moral distress persists, you're constantly being exposed to situations in which insurance companies or your employer prevent you from being able to provide the type of patient care that you know that your patients need. That leads to moral injury. It's experienced as a loss of trust in oneself, authority, and systems. So if all of this is a little bit confusing, I have sort of an allegory, and maybe some of you are familiar with this meme. But imagine you and your colleague are sitting in a room, and my gosh, it's hot. And then suddenly you see your colleague pass out, and everybody rushes in, they resuscitate him. And then when you ask the question, well, why did that happen? People say, oh, gosh, he was wearing a down jacket when it was, 90 degrees in this room. If only he had removed his jacket. If only he had done all these different things that would have allowed him to put up with the conditions in which y'all were working. That's burnout. Burnout says, give them fans, give them sort of ice packs to cool down. It's focused on symptoms and the syndrome, whereas moral distress and injury says, well, look, there's actually somebody who has their hand on the thermostat, and insidiously, they've been turning up the heat in the room with this idea that maybe that will get us to work more quickly, more efficiently, more productively. Moral distress and moral injury seek to understand the root causes of our failing healthcare system. So a couple of knowledge gaps that sort of led us to this work. So moral injury skills, as I pointed out based on Wendy Dean's work, largely focus on the care of veterans. They talk about the psychological effects and functioning of individuals who are noted to have moral injury. And moral distress has been talked about in the healthcare literature, but mostly focused on single hospitals or clinics, single specialties, say academic radiologists, or specific settings, critically ill patients in the ICU, in which unenviable trade-offs are having to be made. And it often examines specific clinical situations or focuses on inter-team dynamics, how maybe the physician versus the bedside nurse versus the social worker may have different attitudes towards right patient care, or intra-institutional dynamics, but doesn't necessarily talk about the system-wide causes, the sort of the environment in which we're all operating. So in early 2024, PNHP, Physicians for a National Health Program, had an opportunity to advance the conversation. So a little bit about PNHP, much of which you all may know. It's an organization that's been around for, probably now, I want to say like 35 years. It has expertise in physician organizing and coalition building through much of the work that David Himmelstein and Steffi Woolhandler, among many others, have done regarding managed care, HMOs, the corporatization of medicine, and more recently talking about Medicare Disadvantage. And the Robert Wood Johnson Foundation, in light of a provocative commentary that was published in the New England Journal, wanted to better understand what is the effect of financialization, corporatization, the business of medicine. What is the effect of these phenomena on physicians? And so they actually reached out to PNHP to submit a proposal, which was then subsequently funded, and which helped us to do the work that we've done over the last 18 months. So in terms of the overall study, the research question that we sought to understand is, amidst growing corporatization and financialization of healthcare, what are the systemic causes, incidence, and severity of moral distress and injury across a national cohort of clinicians? And we sort of designed this in sort of three ways. We did some physician focus groups initially, we did a national survey, and we did one-on-one interviews. And then some colleagues at Healthcare for All Oregon did a case study and going on with United Healthcare in Oregon. So I want to talk a little bit about our survey, and then I'll get into the interviews. So we had three aims to the survey. We wanted to first identify key systemic contributors to moral distress among this national cohort of physicians. We wanted to understand the association between moral distress and physicians' current consideration to leave their jobs. And then third, we wanted to understand who is at greatest risk of moral distress. Are there certain demographic characteristics, professional characteristics, or practice characteristics that increase severity of moral distress? So accordingly, we asked folks about their gender identity, their racial and ethnic background, their clinical specialty. Were they practicing in primary care or in the hospital? Were they a pulmonary critical care physician or a radiologist? How long they'd been practicing medicine. We did ask them about their self-rated level of burnout on a 5-point scale, none to complete burnout. And we asked them previously, in the past, have you ever considered leaving or left a position due to moral distress? We asked them, where did they practice? Maybe they practice in a VA, a nonprofit state hospital like University of California, San Francisco, or a private hospital like Mayo Clinic, for instance, or Cleveland Clinic. The percent of patients for whom they cared who are uninsured, and the percent of patients for whom they cared that came from minoritized backgrounds. And we had two outcomes of interest: the overall severity of moral distress, and asking folks currently, are you considering leaving your position due to moral distress? So we were pretty humbled, or before I get into that, so how did we measure moral distress? So Beth Epstein, who's a nursing researcher at University of Virginia, had come up with this Measures of Moral Distress in Healthcare Professional survey with 27 questions that looked at moral distress at the patient, team, and institutional level, not really at the sort of systemic level as we had hoped. And for each of these 27 questions, she asked folks, how often are you experiencing these sort of morally distressing situations? For instance, being required to care for more patients than I can safely care for. And how much distress do you feel when you encounter them? And then, you sort of create this composite score that multiplies frequency by level of distress. So I just wanted to set the groundwork such that when we come later, I can kind of understand this. But as I mentioned, most of the questions that she and her colleagues asked focused on, again, sort of at the bedside, within the team, in the institutional setting. So we took 8 of those original questions. Again, we did 3 physician focus groups, and we sought to understand, what are these system-wide contributors? And we heard things like, the health system's goals are lots of volume, more specialty volume, less important is patient-centered care. Institutions cut resources and staff and then milk docs for labor. And one person noted, I fear I've pushed more people into medical debt than the number of lives saved. So we used what we heard from the focus groups to come up with 14 new questions. Things like working within a system that prioritizes financial goals over best patient care, having excessive administrative burdens because of insurance, prior authorizations, and denials of care, and making recommendations to patients that I know that they will not be able to pursue because of their financial constraints. So we got nearly 1,900 responses to our survey. And that wasn't just physicians. Actually, it sort of garnered a lot of interest from a lot of individuals. But of those 1,900 or so, about 1,465 were practicing physicians. And of those, 257 had already retired. And so what I'm going to present in the coming slides is looking just at the 1,208 currently practicing physicians, some of whom have completed their training. They're board eligible, board certified in internal medicine or dermatology or general surgery, and 135 who are physician trainees, that is resident physicians or physician fellows who might be caring for you in the clinic or in the hospital. So of these 1,208, about 61% were women, 66% self-identified as white or Caucasian, and 11% were from backgrounds considered underrepresented in medicine. For instance, African Americans, Hispanic individuals, Native Hawaiian or Pacific Islander. They span the gamut of specialties, but 37% practice general adult outpatient medicine, and 44% practice primary care, including individuals perhaps like Dr. Fouts-Fowler, who practices general pediatrics. And most of these individuals, that is 45%, had been in practice over 20 years. So they were quite seasoned as clinicians. Percent practice in public institutions, again, like Veterans Affairs hospitals or clinics, university, state university hospitals. Less than about 68% care for patients for whom less than a quarter are uninsured, and 33% care for a panel of patients in which 26 to 50% come from racially or ethnically minoritized backgrounds. So in terms of self-rated burnout, on average, 37% of individuals consider themselves moderately burnt out. Only 1 in 8 individuals reported no burnout. And there was no significant difference in average burnout between physician trainees and those who'd completed their training. In terms of considering leaving due to moral distress, so 7 in 10 individuals had previously considered leaving a position or a job due to moral distress, of whom 1 in 4 had actually left a position. They found it intolerable to continue working in a system that didn't allow them to care for patients in the way that they had been trained to do so. And that included 1 in 2 physician trainees, people early on in their training. They haven't even reached the cusp of independent practice. And in terms of those presently considering leaving a job due to moral distress, 1 in 4 endorsed this, including 1 in 10 physician trainees. So in terms of the overall severity of moral distress, so again, we asked folks 22 questions. 19 of the 22, they experienced at least sometimes, a 2 out of 4 on this sort of Likert scale. And for 18 of the 22 questions, the most common level of distress was very distressing. So even if they only experienced it infrequently, when they did, they thought it was very distressing. And that overall severity of moral distress, combining both frequency and level of distress, sort of spanned the gamut. So the maximum was 350, the lowest scores were 0, but the mean was 143. And in the original survey that Beth Epstein and her colleagues did back in 2019, their reported mean was 96, recognizing it was a slightly different set of questions, different cohort of individuals. But we think at least some of this is due to the fact that, again, we're touching upon these systemic contributors, things that go beyond the clinic or the hospital at which people are working. So what contributes to the greatest moral distress among practicing clinicians? First, having excessive documentation requirements that compromise patient care and interfere with work-life balance. Feeling betrayed by a healthcare system that hinders one's ability to provide good patient care, and feeling unable to provide patients with the best possible care. Having excessive administrative burdens like documentation because of insurance, prior authorization, and denials of care. Making diagnostic or treatment recommendations to patients that one knows that the patients will not be able to pursue because of healthcare system limitations. And feeling the financial goals of one's organization conflict with one's own goals of best patient care. Who is experiencing more severe moral distress? Women compared to men. physician trainees compared to those who've completed their training. Those caring for increasing proportions of uninsured patients, as well as increasing proportions of racially or ethnically minoritized patients. Those with greater self-rated burnout. And for the 1/4 of physicians currently considering leaving their job due to moral distress was 55% greater than for their colleagues. So this is all sort of, behind all of these numbers, there's a story. And that's what I think, similar to what Dr. Fouts-Fowler was sharing, I think that's what sort of brings a lot of us to this discussion. And so among the 1,208 respondents, we interviewed 30 individuals to uncover narrative themes around how financialization has contributed to moral injury, exacerbated systemic racism, affecting patients, physicians, and communities. So who are these 30 practicing physicians? 18 were women, 11 were men, one person chose not to disclose their gender. 27 were fully trained physicians, 3 were physician trainees, and they came from across the spectrum, again, of clinical specialties. And we asked them questions like, what brought you to medicine? Why did you choose medicine? How did you choose where you practice in terms of the community or the employer? How have you seen physician autonomy changed due to financialization in healthcare? What does moral injury mean to you? How do you cope with everything that you're dealing with when you're not able to care for patients in the way that you know that you need to? So a team of 3 individuals read through all of the transcripts and applied different together in this code cloud. And by and large, these interviews focused on discussions of the impact of the business of medicine, thinking about folks' professional trajectory. What are they doing when they're feeling moral injury? How has the business of medicine affected professional autonomy? Talking about what moral injury means to them and the role of health insurance. So I'm going to present three themes that we distilled from these 30 interviews, kind of as illustrated by some quotes. So theme 1, systemic priorities that favor profit maximization undermine patient care and health outcomes. So a few of the quotes I'm going to present actually come from our colleagues in Oregon, speaking with patients and their family members. So one individual said, my mother-in-law needs 2 knee replacements, but very specifically was told, nope, your insurance company does not cover that, even though the doctor says that's what she needs. We're not covered. Similarly, another person said, the doctor will say, it's not covered. Let's go to plan B. Or they'll spend hours of paperwork trying to get it through. And my doctor has said, yeah, I'm going to try really hard to get this for you, but I don't know if I can. And specifically in Oregon, there have been a lot of buy-ups by United Healthcare of independent physician practices. And so one individual in one of these communities said, United Healthcare created that. They said to doctors, if you're unwilling to see this many more patients per day, cut your appointments down to 20 minutes. If you can't follow the system, then you're out. When Optum bought Oregon Medical Group, this independent physician practice, they lost 30% of their physicians, and they all left the area. One physician reflected, patients and people outside of the medical community will see doctors as part of the problem. We're not happy with that fact. We can't get you the medicine that you need. We would rather be on the patient side than on the team with the insurance company. So insurance utilization review impedes patient-centered care. So one physician reported, I'd rather just make the decisions based on the medical care I'm providing and the patient in front of me. So the prior authorizations, these peer-to-peer requests to justify the care that I'm providing. I did a peer-to-peer recently, but to get the peer-to-peer started took me 20 minutes on the phone. It turns out that the number I had been given was actually not right, and there was a third-party group managing the peer-to-peer requests. I mean, I spoke to 3 different operators, and then when I finally was able to access the other physician to do the peer-to-peer request, it was cursory and useless and did not inspire confidence. It was clear to me that the entire peer-to-peer exercise was administrative burden to alienate my patients from medical care that they were entitled to. Our second theme was that financialized and corporatized healthcare structures deepen disparities for underserved populations. So one physician said, hospitals are motivated by getting good reimbursement. So for people that are on Medicaid or don't have insurance, there's not a financial incentive to give those people the best care possible. Or another reported, you have a system that is predicated on profit maximization. Even the nonprofits engage in profit maximization. We had patients that couldn't afford their inhaler, say for asthma or COPD. They couldn't afford basic medications. They couldn't afford insulin if they had diabetes. Many of our racial and ethnic minorities are on the bottom end or on the lower end of the socioeconomic scale. They have fewer financial resources. So then you're sitting in clinic chewing out your patient because they're not taking their diabetes medication, but they can't afford them. They can't afford it. And finally, theme 3, physicians experience moral injury when corporate and institutional pressures conflict with professional and ethical standards. Every field, so doctors, I think, have been sort of labeled as sort of heroes. We kind of, this idea that we're trying to save everybody, but don't realize the limits of medicine. So this physician said, every field of medicine has things that it can't do. We can't save everybody. But the bigger problem is that for a lot of patients, the treatment that's possible falls short of the treatment that would work. Patients are not the center, and the insurance companies don't even at this point lie about. It's all about the codes. I didn't realize I became an ICD-10ologist, but apparently I'm that. And I'm a CPTologist, so this is current procedural terminology that the American Medical Association controls, and an E&M codologist. That's not what I got into medicine for, to learn all this nonsense. When we talk about burnout, it makes it sound like it's my fault or my colleague's fault. The term points to the person being affected. It's a form of victim shaming. If the canary is dying in the coal mine, you don't talk about making a more resilient canary. You talk about changing the conditions that are harmful and are dangerous. Corporatized systems take advantage of physicians' profession. So one physician shared, the patient may not be able to afford the Band-Aid and that they have to go out and buy out of pocket from the drugstore. So trying to find ways to help that patient do that, I was expected to do all that in 15 minutes. It's not doable. Myself and every other provider end up working 2 hours over. Then you document after that, and it's exhausting. It's unsustainable. I would often not be able to go to the bathroom. I was eating and charting when I had a baby. I was calling patients while pumping, and the patient would ask, "What's the noise in the background?" And I was like, "Oh, it's nothing. It's a machine in the background. Don't worry about it." It was unsustainable, and I really do think the system takes advantage of the professionalism of the docs. And what results is a feeling of guilt and complicity from having to put up with all of these things and try to be as ingenious and as possible. So another physician reported, "I almost feel the sense of complicity in taking part in the system that doesn't feel very patient-centered. Rather than pushing back and saying, I can't see this many patients or I need to have ample time, I feel I'm becoming the face of this healthcare system that's not providing adequate time to these patients. But am I complicit in this by participating in and helping support that kind of system? And on the days that I do get through every patient in 20 minutes, is that just signaling to them, hey, 20 minutes is enough. They can go down to 15. And so there's this lingering sense of almost guilt. So to sort of briefly summarize, if I might, so of the 1,200 or so practicing physicians, 37% reported moderate burnout. Mean moral distress and injury was greater than that previously reported in the literature, in part because, again, we think that we're touching upon these systemic contributors to moral distress. The level of distress often exceeds the frequency with which morally distressing situations were encountered. Excessive documentation requirements, insurance-imposed administrative burdens, and conflicting financial goals contribute to that moral distress. 7 in 10 physicians, including half of physician trainees, have considered leaving or left their jobs due to moral distress. And a quarter of physicians are currently considering leaving a job due to moral distress. But I think the narratives from our interviews illuminate the fact that the business of medicine is undermining physicians' ability to provide their patients with evidence-based, compassionate care, and leaving them searching for how to cope and to preserve a sense of purpose in their day-to-day clinical practice. So, for those who are healthcare workers of any form, I just want to say you're not alone. Moral distress is shockingly common among physicians, and I think that's why we're here today, to organize, to continue the conversation, to build power against the systems that seek to obstruct and impede patient-centered care. moral distress should not be seen as an occupational hazard of practicing medicine. And as Healthcare for All Ohioans, PNHP, and others are saying, we need to share our stories, we need to organize so we can build our movement and advocate for change. And I think to that end, if anything that I've shared today or anything that we talk about sort of gets you thinking and wanting to do more, on March 24th, we'll release a report that summarizes these findings as well as others and talk about sort of next steps. This is just the beginning. This is not the end, as is often the case with research, but it's where do we go from here? So I'll put this up here just as a thank you to our funder, the Robert Wood Johnson Foundation, those who worked tirelessly on this project, our colleagues in Oregon, as well as all those who responded to our survey and those who shared their stories. And with that, happy to take questions, but also would love to hear folks' stories and reflections on what I've shared and what Dr. Fouts-Fowler shared.
Very well. Thank you, Dr. Habib. That was a wonderful presentation. Very, very down to earth for folks of us who aren't physicians. I thought it was extremely enlightening. I know that there are some advocates in the early part of time that I got involved in this advocacy. I knew someone who was another organization, and she talked about doctors as though they believed that they had a money press. They could print money. They believed that doctors were the problem. I said, I don't think that's the problem. And the canary in the coal mine quote that you had from the one guy, that you need more resilient canaries. That's not the point. So I know a particular politician who likes to wear a canary in a cage on his lapel about being watching out for workers. So I'd like to bring that quote to him in the chat, and I'd like to read one here from one of our folks here in Central Ohio. Bob Crazen asks, many patients lost their health insurance because of non-renewal of the ACA subsidies. On January 1, 2027, about 2 million Ohioans will lose Medicaid. What is this going to do to the provision of healthcare, in your opinion? Either doctor.
I guess I can start more globally and say, if our survey and our interviews are any indication, then physicians, clinicians of all sort are already being squeezed. They're already thinking about, is this a sustainable practice for me? And I think increasingly, if folks are losing access to health insurance and the preventive care and the primary care that goes along with that, that means more people are going to show up in hospitals. There's going to be fewer clinicians to care for them in the hospitals. And it's going to lead to more financial distress for communities and also poorer population health outcomes. I'd be curious, I don't know if it maybe Mr. Crazen was also talking about some of the legislation in Ohio for single payer, how that might address the loss of health insurance. But that's sort of globally how I think about it.
Right. Let's see. I can read another one from Eliza Wiedenbaum. What if we focused on and rewarded a hospital's clinic's reputation for good care? What if that were formally focused on, incentivized, and financially rewarded by governments and insurance companies? So then doctors could always do what would keep the medical system in the highest regard of patients, families, and communities. Do either of you doctors have an opinion on that one?
I think it would be wonderful. I think it would change things a great deal, because right now reputation, I think, is as important as a revenue. If people think highly of your place, I think probably most people think of the Cleveland Clinic and they think, oh, the best heart care possible. If we started to tie in reimbursement to actually the outcomes on patients, that would be excellent for everyone.
Problem, though, is that insurance companies and clinics, hospitals aren't giving you that time, right? That's in fact the moral injury, right? I mean, I felt like when I went to the Ohio State University, I changed because I just felt like an insignificant person, because it's so massive and so big. and it just keeps growing. I just felt so insignificant. I switched to a much smaller clinic where there's, one floor you walk in, you're there in your doctor's office. It's not this massive thing. I mean, it seemed like I walked miles once I got into the building. James Binder.
Yes, I just wanted to say a thought about the quality. There was an article written by a number of members of PNHP many years ago about quality, and they looked at the way quality really improves because quality measures that are done now to try to get people to do better quality really are not based on sound principles, and studies show little effect. A single structure totally. And during the time to go through all that, it's not just that you would make access for everybody and everybody would be getting the same care, which would be a huge part. We'd be putting more into preventive medicine. There would be accountability of the community and doctors. There are a number of things I would recommend that people look at that for quality, but the idea of quality the way it is done now, it misses the point totally. Anyway, that's all I want to say.
Good point. Nina, you have a question? Go ahead. Go ahead, Nina.
I wonder if you all could comment on the move for efficiency by having remote exams and in-home care. I had the experience of when I was at Cleveland Clinic in the geriatric clinic, that my primary, with my agreement, we switched over to having my checkups remotely. And what happened was, because nobody was taking my blood pressure, and I assumed I had wonderful blood pressure, that I had an emergency eventually of it shot up to over 190, and I could have had a stroke. So going to these remote appointments have their dangers.
Either doctor would like to comment on that? There you go.
I guess what I would briefly say is, I'm sorry that happened to you, and I think that I would say two things. One, I think we're still trying to figure out how to quote unquote right size care. For whom and for what scenarios is it appropriate to do, telemedicine, virtual medicine? I think because of some of the challenges with the way in which clinicians are distributed, if you're in an area where it takes you 30 minutes or 30 miles to drive to a primary care clinic, then telehealth seems like a nice solution. But the problem is things exactly like what happened to you, Ms. McClellan, then occur is where we sort of put up with sort of good enough solutions and we don't fix the underlying problems. That is, how do we ensure that there's equitable and access to healthcare to individuals regardless of where they live or their financial means? And I think, as I sort of mentioned at to answer the first question, I think it's as the cost of medical education, but also nursing education, NP school increases, as loans for those also go down because of recent legislation, and because of sort of the incentives that healthcare institutions have to sort of center themselves and populate in areas like big cities or medium-sized cities, then folks start to lose out in terms of access to a primary care doctor or somebody who they can see reliably and easily.
Thank you, Nina. Kathy, you had a question from the chat.
Yes, from Debbie Silverman. If you wanted to read your own question, you probably have better audio than I do, but I'm happy to. There you are. I'm going to mute myself.
Okay. So as physicians are driven out by moral injury and outrage, it seems that next level practitioners, nurse practitioners, physician assistants are dominating more of the healthcare delivery market. Aren't they going to be subject to the same pressures? And how is this shift to second level practitioners going to affect all of medical care? We're becoming the minority.
So before I went to medical school, I actually was a physician assistant. So I kind of saw it from a couple of angles. And there is no doubt that NPs and PAs have an incredibly important role to play in healthcare. I very much worry about the price tag associated with becoming an MD nowadays. The majority of people have over $300,000 worth of debt. So, now if they can't take out loans, as Dr. Habib was mentioning, with the new legislation, then I'm worried that it's going to be an increasing loss of physicians. And I do think that the NPs and PAs are going to experience the exact same thing. The only little bit of caveat there is that they are overseen by a physician in most places. So there's still a physician that is in theory, overseeing that. And I think those physicians are going to become less and less able to handle the large amount of mid-level providers that are needed as well. So yes, I think it's going to affect everybody. I think it is affecting everybody.
Good question. Kathy, you have another one?
Yes, I do. Arlene Sheik asks, what is being done now or needs to be done to reduce racism? I assume racism in the practice of medicine.
Big question, $100 million question. I think in some ways, and I think, I don't know if this is in this interview or in this study or some other study, it's the health inequalities that we have that result in medicine in some ways just reflect the social inequalities in our larger society, and, just in terms of wealth inequality and sort of the intersection between wealth and race and ethnicity. I think to sort of disentangle that, I think there's still a lot of implicit biases that many of us have when we're healthcare providers that we need to confront. But I think there's also, the structural inequities and access to care that sort of align themselves along racial and ethnic lines. So where are, hospitals and clinics located? To what extent are there vestiges of redlining as well? So I think single payer and Medicare for all is one step in that right direction where we sort of guarantee access to everybody. You don't have to pay at the point of care. There's no deductibles, no premiums, no copays, no co-insurance to take that element of financial catastrophe out of the formula. But that in and of itself won't necessarily sort of guarantee equity. I think we still see sort of inequitable health outcomes to some degree, perhaps not as badly as in the US and say the UK and other single payer countries. So I think single payer is one response if we can get there, but we also need to sort of be brutally honest with ourselves when we're falling short.
So I am just still pondering this study. I think it is so important. And I'm wondering, so that I can explain to other people, where you had 1,886 respondents. And I'm wondering how many surveys were sent out, or how many people, how many requests to participate were sent out, and how were those people selected to be a part of this study?
Yeah, that's an excellent question. And I think one of the things, perhaps one of the reasons why prior studies had focused on just one hospital, University of Virginia, or one specialty within sort of a city is you have a very clear sampling frame. You're like, okay, there are, 1,000 primary care doctors in Cleveland. We have the email address and we have the mailing address of all of them. We're going to kind of send it out and then we're going to do follow-up. We didn't do that. So I want to be fully transparent. One of the limitations of the study is I can't tell you the response rate. Of those 1,900 people who responded, how many people could have responded? And to what extent are people who responded versus didn't respond different in some way? So there certainly could be selection bias. How we went about this study, and there have been other studies published in literature that did this, is it was kind of a convenience sample and snowball sample. So we'd have, we did some purposeful outreach to entities like Society of General Internal Medicine, American College of Physicians, American Academy of Pediatrics. And hey, can you share this with your members? How many people actually received those messages and then ultimately chose to respond? Unfortunately, I can't tell you. And I think that's sort of, trying to figure out how can we sort of achieve as broad a response as possible and as representative. I think there's an inherent trade-off in that, but your point is well taken.
Bob Parker, you have a question?
Yes. In your study, did you find any difference in doctors who work for the normal type of private hospitals like Cleveland Clinic or University Hospital compared to ones that were working for the private equity run hospitals and firms?
So we didn't specifically look at that. I think that was one of the things that if we could have asked it, we should have. But what we did find is that individuals who practice across types of institutions, say, for instance, I work at a VA, but also a private nonprofit hospital, experience more moral distress. And I think what I would say to that is probably that when you start to see that the way in which healthcare resources, whether it's staff or space or systems, is allocated within our healthcare ecosystem, then you begin to realize, well, over here in, say, the Cleveland Clinic, you have world-class care if you can afford it, if your health insurer is contracted with Cleveland Clinic. If you work in the county or a VA, you work with what you have within the safety net. And so what we did find is that people who work across types of institutions experience more moral injury, in part because I think they begin to realize the vagaries of allocating scarce healthcare resources. But we didn't specifically ask, folks, do they work for an entity that has been bought up by private equity?
One of the questions, and this is coming from actually one of the questions in the chat to some extent, but how is a universal healthcare plan going to address the complementary healthcare forms, things like acupuncture, massage, which have now science-backed, good outcomes in various applications. So I'd like to hear if any of that is coming up within the moral injury conversation.
Excellent question, Kathy. We didn't hear it among folks in our interviews, and some of that may have been that we didn't explicitly ask about it. I think it's a good question in part because I think it sort of speaks to, if we either at the Ohio level or at the federal level, if one day we're able to achieve single payer Medicare for all, the devil is in the details in terms of like what is covered and how it's paid for. And so I think then it sort of speaks to questions of, do traditional and complementary and alternative medicines, are they paid for? How widely available are they? But it didn't specifically come up among folks with whom we spoke.
Ms. Silverman, go ahead.
I think one of the biggest problems is that we do not have any health care in America. We only have sick care. And it started back with the Flexner Report. We outlawed anything that was holistic or alternative or integrative or natural, which is a lot cheaper. And preventive care is lifestyle medicine. That's going to be more about nutrition and natural things. And it got outlawed with the Flexner Report and everything since then. I do a program called Pharmacracy, how big pharma took over the world. And I start out and introduce it with the feeling that I was brainwashed in medical school. I've had physicians walk out as soon as I said that, and they never even heard the presentation. Our orientation is backwards. And I saved myself from burnout in the 90s when I discovered functional medicine and integrative medicine. And all of a sudden it was like, oh my God, if we could prevent all this illness, we don't have the drug costs. We don't have to teach people how to be healthy, but we don't teach that in medical school.
I agree. I think as a pediatrician, I feel very lucky because I have these new people to help lead a healthy life. And I think that's one of one things that I really like. But I do agree that preventive care is not, definitely doesn't bring in the money like sick care does.
Right. Well, I think it's an old Ben Franklin thing, an ounce of prevention worth a pound of cure. If you can prevent that illness, that chronic condition, you know. Other questions?
Yeah, I just wanted to add something. Can you see me, Dina Magulius?
Oh, there you are. Yes, go right ahead.
Hi. Yeah, I'm a physician, and besides the corporatization of medical care and fighting with insurance companies, I think the thing that stresses me out is our society is uh, so dysfunctional. So I do geriatrics, and I see a lot of people that shouldn't be living alone, and they might have some mild dementia, and they need to go live in an assisted living, and they can't afford it. So, and their health insurance won't pay for home health aides, so they're just living alone and struggling. And but anyway, so there's a lot of social needs beside medical care. There's need for good housing and for the elderly assisted living that we would pay for. Um, there's need for food. So, like someone said in that presentation, how can you tell somebody that's diabetic to eat better when they don't have money to get food? So, I mean, our society has cut out food stamps. Um, you know,
Oh, yeah.
and,
Yeah.
there's so many ways we don't have affordable housing. People are, this week I spent, my nursing home where I work half a day a week. We're getting a lot of people who live on the streets and they end up in the hospital with infections or with broken bones. And so we keep them at the nursing home for 2 weeks and then we send them back to the shelter and to the streets so they can happen again. So this whole our society, the lack of housing, the lack of food benefits, there's a lot of things that would help people's health beside just medical care. So that's basically.
Yeah, absolutely. I think most of the people on this call would probably agree with the economic distribution of the wealth in the nation is way out of balance, and that's causing an awful lot of other things. There's no doubt. Other questions on the topic of burnout?
Hi, this is Eliza Weidenbaum, and I'm curious about culture and the contrast of different settings creating burnout. I pay a fair amount of attention to Doctors Against Genocide, Doctors Without Borders. I have more of a pre-hospital EMT training background. And so there are situations from Cuba to Palestine to South Sudan, et cetera, that are often on my mind. And it would be amazing if American doctors are actually having just as bad burnout as people dealing with shrapnel injuries and, drone sniper injuries or deaths. Those don't live. And versus when you sometimes have really amazing culture in a team of people in a difficult situation, but you're doing a good job of improvising with less, and you don't have the 15-minute time pressures, even though you may have a long line of people at a refugee camp or something. My mind just goes to all these other scenarios, which also drive burnout and keep me away from working in them because, like pre-burnout, I'm not going to put myself in a situation which sounds too distressing. But yeah, I don't know if it's worth comparing or not between different types of stressors. Some medical people obviously thrive under a certain amount of these challenges. But if you could speak to any of that, thanks.
Whether the doctors want to talk to that issue, I mean, it's sort of analogous to the pressure of time crunch and number of patients to need to be seen to the trauma she's really talking about, say, for example, in a medic or a military army surgical unit or something like that, or an urban hospital that has a lot of GSWs. I mean, gunshot wounds. Dr. Habib?
Wendy Dean, who was a psychiatrist who primarily worked within the VA, who kind of maybe popularized the idea of moral injury in medicine a couple of years ago, I think she's quite transparent that most of the discussions on moral injury arose in the Veterans Administration due to, military personnel and sort of this conflict of like, okay, I'm being told there's a rigid hierarchy. I have to do X, but my conscience or my belief in and sort of doing that feels at odds with, my humanity, perhaps. So I think there is some analogy there. I think the second thing is, to my knowledge, and maybe I need to do further digging into this, I don't know if there's been a lot of like cross-cultural, cross-national comparisons in terms of, to what extent do clinicians or physicians working in, either national healthcare systems like the NHS in the UK or single payer systems elsewhere, say in Australia, do they face less moral distress and moral injury? And so I think there is something to be said for sort of that sense of like pressure and stress and what it does to people. I think the last thing I'll say is, some of y'all may be familiar with Viktor Frankl's book, Man's Search for Meaning, but he sort of quotes, if you have a why, you can put up with any how. And I think similarly, a lot of clinicians and physicians came into medicine with this sort of service-mindedness, this idea that the most, sacred relationship is the one that you have with your individual patient and doing right by them. Recognizing we're not heroes, we can't necessarily produce miracles. And I think increasingly people are like, gosh, I know maybe what my medical society or someone else is telling me is the standard of care, but in order to get people that standard of care, I have to jump through so many hoops. So that sort of why is starting to fade. And therefore it's harder to put up with anyhow, putting up with 15-minute visits, caring for 30 patients in the hospital at a time and saying, well, what is the logic of any of this?
Yep. Extraction, financial extraction, probably. Kathy, thank you for putting that book reference into the chat. If folks would like to look at the Wendy Dean book, Kathy put a link to the Wendy Dean book in the chat. Dr. Ross, you have a comment?
Yeah, I mean, burnout is not just here in the US. I mean, there have been studies on burnout in Canada as well. But those countries are actually looking at it and doing something systemically to fix it and listening to the doctors. In the case of Australia is another example where they've done everything they can to kind of reduce the administrative burden for doctors there, making the billing simpler, making the documentation simpler. So I think that the difference is that they recognize it, that being a healthcare provider, whether it's being a nurse or an EMT or a physician, those things are going to be stressful. We're dealing with human suffering and human tragedy, and people in pain. So those are going to be difficult things for almost anybody to cope with, even if it's just a friend trying to help another friend, or a loved one trying to help a loved one. The point here I'm trying to make is that what we need is a system in order to fix these things, right? To identify the sources of our emotional distress and our moral distress, and to try to do what we can to improve the system. No system, no fix. I mean, I guess that's what I'm trying to say.
Yeah, we've often said in the movement, this really isn't a system; it's a fragmentary.
Yeah.
Whatever.
Well, that's my comment. I don't think we should be so starry-eyed that national health insurance system is going to fix everything that we're facing in terms of difficulties with our lives as caregivers. But when you're in the system is trying to keep you and your patients happy and healthy, it's a very different thing than being in a system where you feel like you're a cog in somebody's money machine. But I guess that's all I wanted to say.
Thank you. Thank you, Dr. Ross. Okay. Bill asks, can we think a little bit about who is in the fight and who else we need to engage? Why are we having such a difficult time getting people's attention? Do either of you doctors have any input on that? I mean, there's an awful lot of other things going on in the world, obviously. War, in fact, but it is difficult. We have a society that's so full of information. We thought these electronic devices that we have would help with some of that, but it seems like it's a fire hose of information coming at everyone, and to focus on one thing or another, it makes it difficult to make progress. I know that I'm often frustrated with the glacial movement towards what we all believe, I think, is a much better system to get equitable care to all the people and patients out there. Um, I'm not a provider, but I sure feel it from the patient's side. My primary care doctor, when I told him about the advocacy that I do, he goes, "Oh, you're absolutely right. The mode of payment affects the standard of care. There's just no question." Ms. Silverman?
I had an older colleague who was a medical doctor, naturopathic doctor, chiropractic doctor, and PhD in neurophysiology from Denmark. And she told me how wonderful she felt the system was in Denmark, where her daughter, who got divorced and had an autoimmune disorder, not only did she get specialist care for her medical disorder, she got social services, she got counselors for the kids when she got divorced. And it's part of this picture of a total, it's socialized medicine. So they attended to the lifestyle issues, they attended to all the other social issues of medicine. But America doesn't want to do that. They're not willing to have 50% taxes go to pay for a system like that. So we're sort of caught between the commercial materialistic on the one hand and a system that gives more, but people have to be willing to pay for it.
Well, but the thing is, on a per capita basis, and even as a percentage of their overall economies, those systems are less expensive when when it's all ferreted out, so to speak. I mean, we are already paying for a system that we don't receive, and that's the crux of it all. I mean, the CBO, I think, estimated 650 billion in savings. We cover everybody. That's half the Pentagon budget.
$650 billion in savings in this country.
Yeah. I want to take a moment real quickly to thank Kathy Caraway for going to DC for the PNHP event and making the connections that made this possible. Kathy, thank you very much for your input and your.
As John
I
Ross
know.
and
Yeah.
a whole heck of a lot of other folks get some credit, a lot of credit for that. So
Yeah, all you guys traveled. That's great. Thank you
we're
all
in
for
this together, everybody.
Yep. So to close out, I'd like to make one more plug for our upcoming event on April the 25th. It's happening April 25th in Columbus, Ohio at the Quest Conference Center. If you go to our website, spanohio.org or healthcareforallohioans.org, we can put that in the chat.
And I just want to say thank you, Dr. Valerie. Thank you, Dr. Anand. You guys are amazing.
Yes, thank you both very much for coming. And the presentation was great. We'll look forward to seeing the full rollout on the 25th, and there'll be a possibility we can get on the webinar with PNHP. Is that correct? Very good. Thank you so much.